Welcome, everyone. Thank you for joining us. We're delighted to have you here, and we are especially delighted to have our special guest today, which is Bill Sage. I'm Robert Klicksman. I direct the Masters of Bioethics program here at Columbia. We also have about 100 people online now watching us, so to people who are joining us online remotely, welcome. Please feel free to ask questions, to email questions, and Samir Lana, our Associate Director, will be fielding those during the Q&A period. So please feel that you too are part of the discussion, even if you are in California or Sloan Kettering or somewhere else in the world at the moment and can't be here in person. I should say that we're delighted to also have a few other upcoming events. On February 29th, we have a wonderful program on sports and ethics with people who've been working with the NFL about, February 27th, not 29th, forgive me. If you emailed for this, we'll send you information about that. We have a wonderful panel of people talking about what the ethical questions are and issues that are now coming up given increased knowledge of trauma to the brain, et cetera, in athletes that raises questions for universities, for professional teams, et cetera. Today, however, we are deeply honored and delighted to have Bill Sage. He is both a physician and an attorney. He is the James Dougherty Chair for Faculty Excellence in the School of Law and also a professor of surgery and perioperative care in the Dell Medical School at University of Texas, Austin. He was here at Columbia as a tenured professor and moved on to wonderful things in Texas. He is also a member of the National Academy of Medicine and serves on the National Academy of Science, Engineering, and Medicine's board on healthcare services and its Committee on the Future of Nursing, an important issue. He is a fellow of the Hastings Center. He is on the editorial board of the journal Health Affairs, which is, I think, one of the best journals in the field. He has written over 200 articles and edited 3 books, including the Oxford Handbook of U.S. Healthcare. He was health law, I'm sorry, okay. All right, health law. Could be healthcare too, I'm sure. He served as University of Texas Austin's first vice provost for health affairs. He's been involved with politics, having directed 4 working groups of the Clinton administration's task force on healthcare reform. He's done many amazing things. He's a leading person in the field of bioethics, and please join me in welcoming him.
No, I'll speak till the microphone takes over, which I think it has. Good. I'm delighted to be here with you. Thank you, Bob, for a lovely introduction. I'll put in a little plug for your February 27th event because it's a fascinating set of ethical issues. I got to be a peer reviewer for the ethics component of the NFL players study a few years ago, and it is very interesting, and many aspects are actually quite troubling, even beyond the risks of encephalopathy. I'm waiting for, this is unmuted, but are you getting the, because it's not getting through in the,
so this is,
it's not getting through in the room, I don't think.
This is the room mic, right?
Now I can do lecture voice. That's no problem.
All right.
So we
This
can.
is room mic. This is recording mic for online.
Oh, okay. I'll do lecture voice.
Okay,
Sorry,
all right.
We can do lecture voice. No problem. Anyway, I'm here to tell you that ethics is the answer to the important questions facing U.S. healthcare right now. It's not a fallback position. It's not a wouldn't it be nice to do this well. It's actually a central aspect of what we face as a country right now. As Bob mentioned, my total immersion experience in U.S. health policy was in the Clinton White House in 1993. That becomes kind of a starting point for what I'll talk to you about. But I want to connect this very much to where we are in the current environment discussing Medicare for All. My hope is that almost nothing I talk about today is something you've heard before. I'm going to make a series of connections that I hope will surprise you, and in many instances, I hope will persuade you. The title is important if one is a health reformer largely of the progressive ilk, but even among the conservatives, one can find health reformers, the last quarter century has been pragmatic. There have been very few appeals directly to principle. And as far as I'm concerned, the most potentially beneficial aspect of the Medicare for All debate is to force us to consider principle for the first time in a quarter century. Here's the major points. It is grossly misleading to think that the United States has an efficient free market system in healthcare that would be turned for equitable goals into socialism through Medicare for All. That is a pathetic and horribly misleading description of where we are or where we might go. The existing system is simultaneously wasteful and unjust. And that, I would say, is not actually obvious to many of the people who participate in or even study the system. I have spent most of the last 15 years working on inefficiency in the system without really confronting the injustices in the system until recently. Second point, this all goes back to Medicare. So we're talking about Medicare for All, which should get us thinking about Medicare to begin with. And Medicare, I'll argue, introduced as much a Gilded Age of U.S. biomedicine as some type of golden era. I said that we've talked pragmatically and not in a principled fashion. I've said that Medicare for All offers opportunities to bring principle in and solve some problems. And although I am very open to many ethical frames being brought to bear on these issues, I actually view it as a major job of the American health professions, and to be frank, the American medical profession taking the lead in asserting a new ethics for healthcare. The system will not change, in my view, unless it has permission to change. And the permission to change in a very practical way is going to come from the American medical profession, if at all. So how many of you have seen this cheerful slide? It's very nice. You know, it's baseball. There's sort of a soccer mom version of this that troubles me deeply. I really like the baseball version of it. But you kind of see what's going on. Three people of different ages and different heights trying to watch the ball game, 3 boxes available to assist them. And this slide, when it's used, is used to illustrate in some fashion that still kind of eludes me a distinction between equality and equity. What I'd like to point out is that what it's really illustrating is the difference between inefficiency and efficiency. You can use 3 boxes badly, or you can use 3 boxes well. And I made this slide to illustrate that the people who are talking about injustice in healthcare are also talking about inefficiency, the same way the people who are talking about inefficiency in healthcare are also talking about injustice. They don't often realize it. By the way, shameless plug, I have an editorial on the connection between malpractice liability and healthcare quality in the current issue of JAMA, came out yesterday. This is the editor-in-chief of JAMA writing last year about rationing in the United States, something that leading editors of leading clinical journals seem to write about every 5 to 10 years over the last half century. And here, I think there's lots of things that Dr. Bachner says well in this, including talking about it being a blight on the U.S. soul to be in the predicament of injustice and inefficiency we currently face. But I really just want to do with this notion of the modern era of medicine began in the 1960s, which is how he opens this piece. He never says Medicare. But in fact, Medicare is why the modern era of medicine, for better or worse, begins in the 1960s in the United States. This is the signing ceremony, LBJ, Harry and Bess Truman, Lady Bird behind. It's a famous picture. This was the first provision of the Medicare statute, prohibition against any federal interference with the practice of medicine or the manner in which medical services are provided. Honored in the breach, certainly, changed in some ways over the years. This was still the Faustian bargain of the Medicare program, and a lot of what we see today reflects this quasi-commitment in the original legislation. So where do we end up today? So you're used to seeing the United States and healthcare costs in other countries, and you don't even need to see which country's labeled where. If it's the highest, it's us. You know that, but you might not have realized this. So the white bars are private spending per capita on healthcare. And not surprisingly, the United States, with its supposedly free market system, spends far more private money on healthcare than anywhere else in the world. The blue bars are public spending per capita on healthcare. What country spends the most public money per capita on healthcare in the world? Also the United States. And people don't realize that. If you think we're flirting with socialized medicine, we already have socialized medicine. We just have a particular brand of Medicare-driven socialized medicine. It's very hard to find a diagram of the US healthcare system and its regulation. I actually love this diagram that I stole from some other person's random health policy lecture. And the reason I love it is you'll see it has public financing on one side and private financing on the other. And they all go through the same organizations and the same institutions and the same mechanisms of payment and the same mechanisms of control. Almost all of which, when you get down to the bottom, are traceable to the self-regulatory privilege and conduct of the American medical profession. And I'm not blaming doctors, I'm pointing out a fact about how we've designed our system. Doctors often have no idea where the control mechanisms are. People who inhabit some of these alphabet soup self-regulatory organizations sometimes don't even know the control that they themselves exert. They think someone else is doing this. The exception might be the ruck, but we can talk about that later. This all is the same system. Other countries that have a private system and a public system, they're very different. This is all mixed. And, not surprisingly, from the 1960s, healthcare spending has ballooned and crowded out spending on everything else. And if we took defense out of the everything else category, what we would be left with is a sliver of annual federal spending. This should be concerning. Do we have a great system? No, we don't. We're the country that everyone wants to rebuild or revisit the system for, and very few people are actually satisfied with it. And by the Commonwealth Fund metrics of performance, we spend the most and get the least. So that's what you know. So that's the Gilded Age, if you will, of Medicare. That kind of puts in relief where we've gotten ourselves today. We've tried to improve this, at least since, the 1980s, when we began to see how much money we were spending and began to sense how little we might actually be getting. And then, my total immersion experience personally was the Clinton reform effort in 1993, and that was the first Democratic administration in 12 years. The Reagan and Bush era were not, Bush 1 era, were not associated with major health insurance expansions or health care reforms done publicly, many through Medicare payment done quietly in the Beltway way. Before that, by the way, Richard Nixon, our last Democratic president in domestic affairs, Richard Nixon actually had a health reform plan that looked rather like what became the Clinton plan, but Nixon, something happened to Richard Nixon. I can't quite remember what. Let me just tell you what killed the Clinton plan in 1993, because these are the same things that are killing reform plans today, and that affected the ACA, Really, basically three things. One, the way the federal government budgets and how political pressures derive from how the federal government budgets. Two, interest groups, no surprise. And three, fear that universalizing health coverage in the United States, asserting a principle of a right, let's say, to health care, would come at the expense of care rationing. Always a visceral fear turned into a potent political argument. And those were the things that were insurmountable barriers to the Clinton era health reform. They are also the things that we saw straight through the ACA era. And several of us who worked from the early 90s through the 2000s until 2010, we would describe the 2000s as a lost decade of American health policy. There were some important things that happened. Medicare prescription drug coverage, some really interesting things happening in the Medicaid program and in federally qualified health centers, and even in retail medical clinics. But in terms of overall policy improvements, there was really very little, and almost everything was either sort of compromises. Medicare Part D is a perfect example. Why do you have Medicare Part D? Because the Democrats said, this is great, we have another federal entitlement to healthcare services, well, in this case, products. And the Republican says, this is great because the first time we're going to take a piece of Medicare and privatize it. And that type of dialectic where each saw a particular proposal through its own lens of ideology and principle is as close as we ever gotten. Everything pretty much that happens during that era you can describe as a compromise or a dialectic. And meanwhile, the market, poorly regulated, unrestrained, generates the rapid growth in inefficiency and consequent injustice that we've seen since the 1990s. And the ACA threads the needle. Threads the needle on these same three issues. It makes itself fiscally palatable. The CBO score is where it needs to be. It's very contrived. It's not meaningful, but we somehow managed to get through on fiscal grounds. By the way, we don't do it with an employer mandate because the Congressional Budget Office would have scored that very differently from the way it scored the quasi-individual mandate. But we get through there. We appease the interest groups. We expand private coverage. We make sure hospitals get a bunch of revenue. And the law, faced with the Sarah Palin death panel accusation, falls all over itself to avoid even the barest appearance of rationing services. And so we get the ACA. I'm a big supporter of the ACA. I think the ACA properly implemented would do very well, but at best, it is pragmatic. And at best, it is consumerist. So to my knowledge, I'm the only person who ever kind of picked up this quote, and it may be because I was waiting for the opinion in King versus Burwell to come down from the Supreme Court in June 2015. I was going to write about it for Health Affairs blog. I have lots of reasons to want to know what's going to happen in that case. This was the statement that President Obama made at the White House when the ACA was upheld in King versus Burwell. And the salient parts are that people are directly benefiting from the ACA but don't even know it. And to the Obama administration, it was okay. In fact, it was necessary because to say you are in the ACA would have been saying we might ration your care, or your care coverage might show up on the federal books. And you see, that's by design. This has never been a government takeover, despite cries to the contrary. The reform remains what it's always been, according to Obama, a set of fairer rules and tougher protections that have made healthcare in America more affordable, more attainable, and more about you, the consumer, comma, the American people. Okay, the glass half full, this was politically feasible. The glass half empty, the American people are not just consumers. And to think about our healthcare system in purely consumerist terms is to renounce a lot of potential principle. And from the very beginning, from actually before the law was even signed, I said it should have been called Americare. And it should have had the symbolism, it should have had the support, it should have had the solidarity and the patriotism. We never got Americare. So where does this kind of get us today? Something that is not often appreciated is that the major brands that are associated with national health reform, whether you want to call it single payer or Medicare for all, whether you want to call it managed care or managed competition, whether you even want to call it, consumer directed care or something that comes off of the political right and is more concerned with consumer moral hazard. The brand names survive, but what we understand about our system has changed very dramatically since the early 1990s. And I just want to point out 4 things that we now know about the system that we didn't realize then. The first 2 are things that are often discussed. The last 2 are things that I spend a lot more time on and are less often discussed generally. So the categories are from rationing to improvement, social determinants and unjust disparities, what I would describe as the inertial force of health law. Bob, this is the book that I keep trying to write and never, unlike you, I never succeed in actually getting a book done. And then the latent power of generational change, which is something that in the world of the professions, which I work on at many levels, we seldom acknowledge. And it's generational change on both the professional side and on, for healthcare, the care recipient side. I just want to point out something fundamental about how we think about our system, which goes to the accusations of rationing that are hurled at most Medicare-for-All style proposals. Back in the 1980s into the early 1990s, when you learned health policy, you learned it as a 3-legged stool of access, quality, and cost. And you thought about these as characteristics in necessary equipoise. That if you wanted more access, you had to pay more or suffer less quality. If you wanted to save money, you had to restrict access or reduce quality, etc. And this was well captured in a book that Bill Kissick wrote in 1994 that I would argue was outdated the moment it appeared. But his experiences and his insights were powerful. But no society in the world, he wrote, has ever been or will ever be able to afford providing all the health services its population is capable of utilizing. And this is how the first few generations of health policy students and students of bioethics learned to think about care delivery in our system as this triangle of access, quality, and cost. Very much coming off of a physician-directed medical model of scientific improvement, of scientifically driven application of care to medical problems. It's not the world we're in today. By the way, if you can get hold of it, I would strongly urge you to read the, or maybe there's a video of it, the address that Don Berwick gave to one of these international quality of care associations just last month. I got hold of a transcript of it. He was nice enough to provide, and we'll come back to a different Don Berwick quote later. But it is really kind of a very similar to the message I'm trying to impart to you, but coming from a somewhat different set of experiences, perspectives. But when you go from Kissick to Berwick, and I assume that people here, by and large, have heard of Don Berwick and the Institute for Healthcare Improvement and the patient safety movement and the quality chasm and things of that sort. You get to the triple aim. So how many people here have never heard of the triple aim? Okay. A couple of people haven't heard of the triple aim. So the triple aim is now how people learn about health policy and in many ways about what's called health system science and care delivery. And it says improving the patient experience of care, including quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. That's the triple aim. There's three things. Cost, access, quality, there's three things. When you first look at this, you say, okay, there's some things that are new. We care about the patient's experience, not just something we would call quality. That's good. We care about populations, not just about individuals. That's good. But people tend to miss the fundamental difference between the cost, access, and quality framing and the triple aim. These are characteristics in tension with one another, inexorably. These are three things that are simultaneously achievable. The whole point of the triple aim is that our existing system is so far from optimal that we can make cumulative improvements that simultaneously improve the patient experience of care and improve population health and reduce per capita cost. And that's a complete reframing. If you're worried in the political debate that every time the government's going to do something, it's going to be rationing care, think how much can be done without rationing care. And we've proved it. I'll also tell you something about the quality chasm. So these are the 6 attributes of a high-functioning system according to the Institute of Medicine. Healthcare should be safe, effective, patient-centered, timely, efficient, and equitable, 2001. The Institute of Medicine, now National Academy. This speaks for the leading edge of the American medical profession and healthcare system. They identified these 6 characteristics, and then they proceeded to say that the existing U.S. system doesn't do any of them. Okay, that's really itself something you may never have thought about. Imagine the leaders of any sector of the economy or society saying, here are the things that we aspire to, and guess what? We don't do well on any of them. That's unusual. And you can see where sources of improvement lie. So that's a really important transition. When we think about any type of health reform today, we can realize that we've gone from we're in equipoise, and if we want to expand, we have to ration, to no, we can do lots of improvement. Second point, also familiar, is we now are in a world of social determinants and unjust health disparities, and we have documented now, these are all, by the way, now being contested. All of these diagrams and pie charts and calculations are actually being worked through now by people with sort of better statistical sense and often better data. So I'm not wedded to any of the numbers here, but the basic insight you all know is a good one, which is most of health is not about medical services. It's about other things. And we realize that now. And we didn't realize that when we were debating Medicare, and we didn't realize that when we were debating the Clinton reform, or we didn't acknowledge it even if we knew it. And now, here's the Virginia Commonwealth maps. These are wonderful life expectancy based on, subway stop or zip code or neighborhood. So here's Chicago. Here's New York City. This is not about access to medical care. And if you look at social needs, poor people have social needs that bear on health. And this is not surprising to any of you, and this is the Betsy Bradley, Lauren Taylor work trying to correlate countries' investments in medical care with countries' investments in health-related social care. And again, the numbers are being contested as we speak, but I think the basic insight is an important one. Other countries manage to have a functional healthcare system at far lower cost and have money with which to do other types of social supports. that also changes the calculation. It's not just we're going to do Medicare for all to give people medical care. We're going to do Medicare for all because we want to improve health. And because we want to conserve resources to use in ways that make society both more productive and more just. And right now we pour that money into medicine. And then just, in the interest of time, I'm just going to kind of give you the flavor of these two issues. This is what I work the most on, because typically if in 2001 the Institute of Medicine said this is what a healthcare system should look like, and we don't do any of it, those are great goals. And then when all these people come up from IHI or out of Harvard Business School or wherever you like and say, here's all the management techniques that are going to improve things. Typically, if you know where you want to go and you know how to get there, 20 years later you should be there. And we're not. And so I sort of take it on myself to try to explain that. And a big piece of this is actually law, which ties back to the notion of not just Medicare itself, but medical care, but health law and regulation and professional self-regulation in general as being a major drag on getting a better system. And this also, of course, leads into the notion that if the profession controls or has been assigned a lot of the sort of structural management of the system, then a reconsideration and an explicit discussion of sort of medical ethics is going to be one of the important triggers to improving the system. But basically, what's happened is that we created a healthcare system where we took a rather idealized image of one physician and one patient with a particularly virtuous and well-informed physician and a particularly dependent patient, and protected that relationship through law. And then we scaled that up to the population level and called it a healthcare system. And I think that was a terrible mistake. It was not ill-motivated, but it is not functional. For the last century, we've had state law conferring privileges on the medical profession, and I think I truncated this slide. The past 50, Medicare, we've had federal law subsidizing financially the system that state law created. And that's another piece of the Medicare as Gilded Age rather than Medicare as Golden Era. One can break this down, and I'm not going to try to do this, but in so many areas, one can find aspects of law and governance and self-regulation that reinforce this single doctor, single patient dyad that fills us at the population level and therefore fills us across a lot of individual patients or potential patients, people as well. Let me just give you one sense, though, of generational change, because this is a hopeful story. And here, I found myself accidentally talking about generational change at a conference up at Yale Law School now about 5 years ago. I'm a utility infielder for Yale Law School meetings. They put me on a panel and they're like, no, we got more people, so you go in this panel, you go in this panel. So they kept moving me around panels. And so where I ended up, I thought, what I really want to talk about is generational change. And then that attracted some attention from a minor journalist who then did some interviewing, which gave rise to the quote that I'm going to show you. How many of you know of Bob Wachter at UCSF? Okay, several of you. At the time, Chief of General Internal Medicine, later Chair of the Department of Medicine. And Dr. Wachter, asked about generational change, told this story about himself to this journalist. He said he talks to the first-year medical student class and gives them sort of introductory, lectures, usually kind of the cheerleading variety. But one day he says he was in a sour mood, and he wanted to put the fear of God into his first-year class of UCS medical students. And so in a very stern voice, he said this. He said, you folks are entering a profession completely different from the one I entered 30 years ago, because you will be under relentless, unremitting pressure to figure out how to deliver the highest quality, safest, most satisfying care at the lowest possible cost. Pause. Hand goes up in the audience. Excuse me, Dr. Wachter, what exactly were you trying to do? This is really important. You know, I trained in medicine in the era that Dr. Wachter. What were we trying to do? If we weren't trying to figure out how to deliver the highest quality, safest, most satisfying care at the lowest possible cost, what in the world were we trying to do? It's really good to think about this. And, you know, I don't want to romanticize generational change or say that I am, you know, an academic expert on it, but there's a whole lot of things that have changed both on the provider side and the recipient side of medical care. And we tend not to notice this because professions have traditions and professionals have long careers, and the washout from as people retire and are replaced is almost imperceptible. And even worse, our political process caricatures professional interest groups, in part because of the structure of professional interest groups, but in part because it's easier to think that doctors 20 years ago were the same as doctors today, or nurses or pharmacists or what have you, than to actually, as a politician, have to think about how things are evolving. But generational changes also. So all of these things, I would just argue to you, really do challenge the branding of health reform to be something other than what we casually respond to when we hear single payer or managed care. We know other things about our system. We have other goals, we have other information, we have other trends. And all of the brands of health reform, including Medicare-for-All, can take account of these in ways that they really haven't yet. You know, campaigning in the 2020 presidential election on Medicare-for-All is not the same as implementing a Medicare-for-all type proposal in light of what we know about the system. Hopefully we'll have an opportunity to do that. Let me just say a couple of things about, you know, the heart here of how you would innovate for Medicare-for-all, but then I want to kind of focus on the ethical piece as conclusion. So there are actually, to my mind, 3 different brands of what Medicare-for-all could mean. These track, to some degree, legislative proposals and candidate positions, but I think it's more important that you just understand these. So one brand of Medicare-for-all is universal coverage. Everyone gets health insurance, and they get it through the federal government by virtue of the Medicare program. This, I would point out to you, actually comes in 2 flavors. One says, well, whatever Medicare looks like today, or particularly fee-for-service Medicare, that's what everybody now gets. The second says, well, you know, close to half of Medicare beneficiaries are currently in Medicare Advantage plans. They're in health plans. Everyone gets a Medicare Advantage plan. By the way, everyone getting a Medicare Advantage plan is probably the closest to a light switch that you're going to get in a Medicare-for-all proposal in terms of how could we implement this with the least disruption and the least potential for mischief. That's a flippable switch in a lot of ways if we do this through Medicare Advantage. But these are with universal coverage goals.
You may just want to say what Medicare Advantage is.
Medicare Advantage is Medicare managed care, what were called Medicare Plus Choice, Medicare Part C for a while. These are the plans that when you see if you're like me and you're watching the impeachment hearings on CNN and they keep airing these Joe Namath ads for, you know, seniors call for your new Medicare benefits and new Medicare options. These are the ads that you would like to think are deceptive and should be pulled off the air, but I can tell you they're not. They're actually true. I mean, there are actually new benefits, and if you are willing to sign up for a Medicare Advantage plan, you give some things up, but you actually will get this typically for no additional money. But there are Medicare Advantage plans. And the funny thing is, if you think, so I'm 59 years old, if you think about the uptake populations, not in rural areas, not in very disadvantaged communities, but if you think about sort of in general notion of who are the uptake people for switching from what we have to a Medicare for all, they're generally people who've grown up in health plans. Maybe New York City or Manhattan's a little different, but I personally wouldn't really know what to do if I had to navigate the bare bones Medicare fee-for-service system. I'm actually much happier if I'd be happy to be in a Medicare for all program, but I'd do it through a Medicare Advantage plan. And I just want to point out to you that in terms of all of the quote costs and all of the hassles that are described with implementing a Medicare for all program, Medicare Advantage for all has far fewer of them. But you don't even have to go to the universal coverage, say that that's deemed unaffordable for fiscal reasons or whatever. The second of the three forms of Medicare for all is just the stronger safety net. So you hear this when you hear discussions of a quote public option. So having a public option, which is now in place in Washington State by way of example at the state level, a public option is a safety net alternative if the private options are not acceptable to enrollees without shifting everybody over, or you can do what I and others will call Medicare for More, which is you take a particular expansion subpopulation and they're the ones who get some form of Medicare or Medicare Advantage. And that's, I describe it as a stronger safety net. And then the third and very interesting category gets almost no play. Occasionally gets play around surprise medical billing or excessive costs, is just changing the rules. So you have Medicare or Medicare-like rules. So Medicare pricing for all, that comes up fairly often, It doesn't really matter what health plan you're in, but, or what provider you go to, but they should be paid for you the same that Medicare pays them. And there are various versions of that. And that's a rule change that would implement a Medicare for all type proposal without the coverage expansions. It doesn't have to be payment. It could be nurses have practice rights and prescriptive authority. It could be certificate of need laws go away. It could be there's some other sort of guarantee or promoter of competition among hospitals. Using a federal baseline. The Veterans Administration system, the Veterans Health System has this now. At a local level, they can depart from state law to run their own systems. You could do that across the board. And then, there are the people who, instead of Medicare for all, want Medicare for none, which comes from the other political party and from a much more conservative direction. But if we are kind of hypothesizing all the things that could be done using the Medicare frame, changing Medicare in that direction is certainly one that should be on your radar screen. I don't support it. I don't know many health economists who do. And when you put these things together, you actually could begin to address those kind of just above ground level big problems that are never going to be solved by just one big law and are also never going to be solved by small laws focused on very particular domains. There's lots of things we can say about our healthcare system that we would like to improve. And it's going to take some type of more collective engagement that I think the Medicare for All frame does offer us to begin to do that. You realize, of course, that American health insurance companies almost never actually provide insurance. They process claims, and claims are a strange contrivance that providers have come up with so that they can get a billing code and receive reimbursement. None of this really ties necessarily to where the money's coming from or where the money's going. It's just how we do this. There can be some very innovative insurance companies out there, but at the end of the day, American health insurance takes a cut of the revenue flowing through the system and has almost no meaningful incentive to reduce the amount of revenue flowing through the system. It's not bad motivation, it's the structures that we have. Self-care. I mean, why is it so hard to deal with a sprained ankle on a Saturday night? It doesn't make, we have designed a system and supported it through law that makes it exquisitely difficult for people to take care of their own medical needs. It's not necessary. And we have now begun to recognize that many of our social problems we have filtered through a medical lens, which we excuse as being a way of diverting some funding to social problems that we fear would not otherwise be available, but comes at a tremendous cost. My mantra here, which was the title of an essay I wrote about a year and a half ago, is if you wouldn't criminalize poverty, don't medicalize it. There are some significant risks associated with how we've approached this. And so that kind of gets me to the end, and I'm sorry I got a little carried away here in terms of time for questions, but I will be brief here. I have done in my world of medical education, helping do some of the planning for what's now the Dell Medical School in Austin, which I'm very proud of, graduates its first MD class this spring. Wonderful people who are going to go on to great careers. I was involved in devising a leadership curriculum for the medical school. And then that made me sort of look out and see what other schools were doing well teaching leadership in the professions. And what I came to believe is that the way I look at leadership in the professions is that leadership is forward-looking ethics. A lot of the ethics that we have taught tends to be backward-looking. It's very nostalgic. Maybe it reflects a simpler time that did exist. I suspect that often the time was not as simple as we pretended to have been. But I like to think of forward-looking ethics as the proper frame for teaching leadership. And various people over the last few decades of pragmatism have had these voices of saying, wait a minute, we can't make this change in our system until we have an ethical frame that will support it and implement it the right way. And Jerry Kassirer, who was the New England Journal's editor-in-chief for several years in the 90s, and who I would read and say, I don't agree with this. I now actually look back and think, he was standing up for ethics, and I think it was admirable. And a task now, I think, is to reformulate medical ethics. It doesn't mean sort of departing from things we hold dear as core professional values, but it's taking responsibility. Most of the things about our current system that do not change, the lack of change is excused by people claiming that this upholds traditional medical ethics. At so many levels, it's what boxes us in. And as far as I'm concerned, if the health professions, and I do a lot of work on nursing and other health professions and on interprofessional education, but it is really doctors who have to lead here, because doctors are the fallback and doctors are the controllers of the system we have. And here are just some speculations. An ethical frame that supports social investment even when it's non-medical social investment. Explicit attention to injustice. I'm actually very encouraged, at least as a matter of descriptors, that words such as social determinants are fading in favor of a notion of health justice. There's a lot of baggage associated with the language that we use in trying to kind of show that we understand the effects of poverty and race and other sources of discrimination. We're trying to evolve the right language. Right now, I think health justice is a pretty good descriptor. We'll see where we get in the next few years. Compassion. I like to think of this looking forward as what aspects of healthcare can't be machine learned and automated? Those are the qualities that need to be the ethical frame for healthcare going forward. Communities, groups can't always just be about the individual patient. And then I think the one at the end is a complicated one that I've only begun to play with, which is part of what we confront in society and politics is attitudes towards science. And I think the healthcare system has built itself on a view of science that is no longer the most socially productive view of science. And I think that needs to be reevaluated. I don't claim to have the answer to that, but I want to ask the question. And where this ends for me is where it actually ends for the healthcare technocrats. And so here's not just Don Berwick writing 5 years ago, but Avidus Donabedian in his sort of deathbed interview for Health Affairs with Fitzmullen. These were the people who were all about measurement and reproducibility and accountability, and look where they ended up. And if you can find Don Berwick's last month keynote address about healthcare quality, it's all about morality, it's all about compassion, it's all about love, it's all about social engagement beyond the narrow aspects of sort of technically focused medical care. And this is where I hope we will go. And this is sunrise at my house on the coast of Maine. And we can end there. Thank you.
Great, thank you, and I hope you do write the book soon.
Do quick questions.
Questions.
You call on people.
Okay, let's do 3 questions.
Thank you. Wonderful presentation. I'm really glad the questions that you asked. Thank you. On the terminology and what we're grappling with, one thing went by very quickly that I want to point out as the biggest moral problem I think that we have in trying to change medical care, and that is the dependence on observational research and blaming the victim. 40% behavioral determinants of health. Probably I didn't catch it, but probably the rest of it was nutrition. None of that is proven, and until we figure out how, as a society, we're willing to help people change their behavior, we got nothing.
Let's get 2 more questions rather than answers, and then I'll say something.
Yes. So you just had in the last slide the social investment in health to favor potentially non-medical to medical. Oh, sorry. So you just had in your last slide one thing kind of forward thinking is to favor some potentially non-medical investment over medical. Within that construct, what would be like the 2 biggest kind of ideas or investments that you would kind of support or stand behind?
Okay, and get another question.
So my question dovetails off of the last one, which is to push you to be a little bit more pragmatic. If you want physicians to lead the way, but physicians are also the ones front line seeing patients. I'm a general internist, primary care doctor. What are some tangible things that we can do to make a difference and start to see some of this change realized?
Okay, so on the terminology, I'm very concerned about the cultural othering that comes from some of the terms that we try to use with good intentions. So the Robert Wood Johnson Foundation brand of culture of health has now, not just from me, but from people who really know about this stuff, attracted a lot of pushback because it is reminiscent of the culture of poverty and sort of the othering of poor America back in the 1960s that created all sorts of mischief, even among people who were very well-intentioned. So we need to work through the terminology and be very careful not to be blaming the victim. I would caution that in acute care medicine, we have often also blamed the victim far more than we should have. In terms of non-medical social supports, I mean, here, I'll come back, and forgive me, it's not going to be about wellness, but I'll come back to my skepticism about medicalizing poverty that is based on criminalizing poverty. In both of these instances, large swaths of society were, for various reasons, often not good ones, afraid to trust poor people with money. And the argument was always, if you give poor people money, they will become welfare dependent. So what did we do? We made them patients, or we incarcerated them. Which is actually more dependent? Being a patient or being a poor person in the community with money? You know, let's be real. So when I talk about, non-medical social supports, a lot of it has to do with trusting people, And in terms of physicians being pragmatic, this is exactly where I really urge you to find, and I'll ask Berwick if I can do this, if I can provide you guys a link or a copy of his speech, because what it's really about is for all the people who are trying to make a difference with their patients, with their metrics, trying to be progressive, you also have to care about climate change. You also have to care about mass incarceration. You also have to go out and make a difference. And I'm not just saying this myself in however you want to perceive me. This is Don Berwick talking to all of the quality people out there. And I think the truth is, for physicians, pragmatically, use these opportunities to talk about principle. It might be, the expansion of health coverage, that's up to you, but it's all the other things that make for a healthier society that we often just treat as not what we should be involved in.
Well, thank you so much for a very eye-opening, inspiring talk. That was great. And again, please join us for our next event, and please join me again in thanking Bill Sage. That was terrific. There's 5 books here.